Hi guys, so we continue with our antihypertensives. So guys, please watch the first part of this series. I'm gonna leave a link on the comment section. Before you can come and watch this video, please watch the first part, which is just it's like an overview of antihypertensives. Because in this part I'm gonna discuss calcium channel blockers specifically. But to get a broader understanding, please watch the first part, the first video. I'm gonna leave a link on the comment section. But quickly, what I want to run over is something I didn't mention on that video. Like I said, stroke volume and heart rate, this is how you manipulate your cardiac output in order to manipulate your BPs, to drop your BPs. And this side we did talk about the preload, contractility, and afterload, right? And I did mention the drugs that we use, the classes of drugs that we can use on each of these. And we did speak about, so I said it's diuretics here, diuretics, here calcium channel blockers, ACE inhibitors, and also hydralazine can be used, because hydralazine is a vasodilator. Then up here for heart rate we've got beta blockers. You know the different types, selective and non-selective. But what I didn't mention on that other video is peripheral resistance. What are the drugs that we can use? The drugs that we can use to actually decrease peripheral resistance, because in a hypertensive patient you want to decrease peripheral resistance so that you decrease your BP, right? So the drugs that have got vasodilatory effects are ACE inhibitors once more, hydralazine, right? Now, there's something important that I want to mention as well. When you are treating a patient with hypertension, you always have to check their cholesterol levels. You have to do lipogram each and every year. That's why you have to take bloods for lipogram every year on a hypertensive patient is because of this reason. If this is a cross section of an artery, when you've got cholesterol, you start to accumulate cholesterol molecules there. Atherosclerosis happens and all of that. So what this does is that if you compare these two, this lumen, there's a higher volume here. Because there's a higher volume here, so the lumen is bigger. So because the volume, I'm gonna say it like that, the volume of this lumen is higher, so which means the pressure is low. The pressure, this is what you want. But the minute you've got some cholesterol that is attached to the intima, what you have done here, you have decreased the volume of this artery or this lumen. You have decreased the volume and you have increased the pressure. So there's so much pressure on this one. So this increases peripheral resistance. It's gonna be hard for the heart to pump against. It's easy for the heart to pump blood against an open lumen with no obstruction. The heart will manage. But the minute you have got a decreased, you've got an increased pressure because of a decreased volume, it's hard for the heart. It becomes harder for the heart to pump against a sclerotic, not sclerotic, sorry, an artery that's got cholesterol, that is full of cholesterol inside. Because I mean, in some cases you find that this just continues, and this causes the heart will pick it up that there's an obstruction. It's going to try to pump against that obstruction so that it can achieve, it can maintain its cardiac output. That means the heart rate is going to go up. That's the first thing. And also the PR, because the peripheral resistance now is high, so the PR is going to go up. So what I'm trying to explain here is that when you're treating a patient with antihypertensives, you're treating them for hypertension, but they've got dyslipidemia, you are likely gonna get to a point whereby you can't, whereby you can't control their BPs anymore, and maybe you would have tried all the other drugs, but nothing seems to work. So always work these patients up continuously, and if you have used one class here, one class here, one class here, but you are still not winning, consider checking for cholesterol. You might find that the heart rate that is high is because of this, and also the PR is high is because of this problem, which means now you have to put this patient on statins. This is the reason why when we're treating patients with hypertension, we always check their lipogram, because we know that if the patient happens to develop hyperlipidemia or dyslipidemia, and you get a high cholesterol, you are likely going to end up having uncontrolled blood pressures. Okay, yeah. So we're gonna move. I'm gonna clear this, and then we're gonna talk about calcium channel blockers. Thank you, guys.